right, I think we'll go ahead and get started. Thank you so much for making time today. Welcome to our weekly updates for the health department. And we'll just go ahead and get started with our metrics. And then I'm going to do a pretty involved discussion about some of the therapeutic options for COVID. So hopefully that'll answer some of the questions that we're getting about what these new therapies are and how we can use them. And we'll have lots of time for discussion. In terms of the metrics, here's our statistics for the county. As you can see, we're kind of in the middle of the pack here in terms of the overall case rates. Case rates are coming down, which is kind of the big headline. But when you look at the fine print, you could see that our case rates are still pretty darn high. And in fact, they're near the peak from last winter. So while case rates are coming down, I really think about this as landing the plane. We want to have a soft, gentle landing, which means everyone still needs to keep their seatbelt on, and we have to keep our hands on the steering wheel. We can't just, throw up our hands in celebration and run around the cabin just yet. We still have a long ways to go before we're actually on the ground. In terms of the variant sequencing, we are seeing more and more Omicron cases. The number that are sequenced are such a small fraction that it's almost absurd. But basically, we've found only about 961 cases of Omicron, knowing that, we've had many, many thousands more, but that's just how much the sequencing results we're able to keep track of ourselves from what the state gives us. The other good news about that is that it's almost all the original Omicron variant. So we all heard about the BA2 variant, which was known as the silent Omicron, the one that's more contagious, et cetera. That has not yet been found in Fresno County. It's only been found in a handful of other counties in California. So while it did create some disruptions and did cause some uptick in cases around the world, it's really hasn't been a major player in California, and we haven't seen any of the BA2 variant in Fresno County. In terms of what's going on with our hospitals, again, the numbers are coming down, but they are still pretty high. We're still in the 400s range, making us in the top 5 of the counties in terms of the hospitalizations right now. We certainly hope that trends in the right direction, and we expect it to throughout the rest of February and into March. But we understand that the hospitals remain quite impacted and constrained. Thankfully, we have new therapeutics that are now available to help protect some of our higher risk patients, and that should kind of help the overall picture. We're also looking at wastewater surveillance. So this is pretty interesting and new. As you can see, we kind of had a massive peak right around mid-January, which really aligned with the peak of the Omicron surge. And since then, even though this is a really messy data, pardon the pun, this basically does show that there is a decrease in the number of copies of COVID and in the wastewater that's being tested. So, I think as time goes on, like I've said before, this will actually help us pick up new surges as they come up, because it's a really sensitive technology. In fact, it's so sensitive that there is a lot of noise here. It goes up and down just, for a lot of different reasons. But during times when surges are not happening, this will actually be a very key player in terms of our ability to track potential surges and new upticks. Just to keep going, here's our effective rate for the whole region. It looks pretty good. It's a lot lower than 1, which means that, again, things are slowing down. And that's basically just another metric that we look at to say, okay, we're now, experiencing a time of decreasing transmission. And I think I have one more metric slide here. Oh yeah, so this is our hospitalizations and what the forecast is. The dotted line is always like the day of, and then moving forward into the future, we see that our hospitalizations are going to continue to decrease from the 400s down to hopefully a very low number. That's what the aggregate projection shows. Same thing with the ICU numbers. Those are continuing to go down. Here's a snapshot of what's going on with kids. So these are pediatric patients. at Fresno and Madera hospitals, so including Valley Children's here. Again, we had a surge. I know that these are hard to read, but this is the January month. So the surge was definitely seen in the pediatric population. And you can see they never had this many kids as we did this January in the hospitals. But thankfully that number is coming down. And even though there are a lot of kids in area hospitals, we expect that number to continue to decrease. I share this in the context of a lot of noise being made about schools and making schools, much less restrictive and getting all the masks off and things like that. And while I do support doing that in a future time, I don't think that today is the right day to take the masks off the kids, because whenever I see something like this, I know that this is actually affecting kids. It's still circulating in our community. And we know that masks do slow down the transmission and help us decrease the number and the size of outbreaks. And all of those are things that we still need to have in place while we're dealing with these high numbers at the hospitals. So you might be hearing different things. I know that there's some impatient voices out in the community, and all of us are feeling that emotion too. Believe me, I am too. But we need to look at the science and look at the data and just, take a good hard look at where we are and just understand that we are definitely not out of the woods, and that our hospitals are still under tremendous strain from COVID and non-COVID admissions. And we need to continue these layers of protection. In terms of the layers of protection, actually right now, I'm competing with the governor who's doing a big speech about the endemic strategy for California. So you're going to see that on the evening news tonight. And basically, this is part of the slide packet that they just shared out like half an hour ago. So this has actually not hit the airwaves yet. And what they're trying to show here is that, the California curve of deaths is actually much lower than other large states, which were quote unquote less restrictive than we were. And so basically just showing that our hard work has paid off. Just in terms of numbers, here's the number of vaccines that have been administered statewide. We've administered 70 million vaccines. So people that say vaccines are not effective or not safe can go look at those 70 million cases and make their own conclusions if they dare about just how safe these vaccines are. I really think that that's such a dumb argument, and it's becoming dumber and dumber because these vaccines are proving to be quite safe compared to non-vaccinated individuals. There's lots of other data here that are there for your perusal in terms of what's been achieved in California. The governor's strategy is going to be called California Smarter, which stands for, it's actually an acronym, called Shots, Masks, Awareness, Readiness, Testing, Education, and RX, which stands for Evolving and Improving Treatments, which will become increasingly available and critical as a tool to save lives. And that actually, whether you like that mnemonic or not, that actually is a great segue for what I'm going to talk about next, which is the actual therapies for COVID-19. So any questions so far about the metrics or about where things are going? So I guess the bottom line is an endemic strategy is coalescing, which will, cover these 7 things at the state level. We don't know what the rules and regulations will be exactly. We haven't been told, but we understand that by the end of the month, we'll have probably new rules for schools and new rules for masking, which kind of have already been put into place this week, but that might get refined a little bit more. And hopefully a new roadmap for, what do we do if there's another surge? How do we make sure people are safe, even with low levels of COVID circulating, et cetera, et cetera. So all of that is yet to be announced, but today is the day that the governor is gonna unveil this California Smarter campaign. All right, if there's no other questions, I'll move on to the COVID therapies. This feels a little disorienting. It feels like drinking from a fire hose because there's so many things that have come down the line. We don't expect all of you to become experts in this. In fact, we have infectious disease specialists and public health specialists and lots of other experts that can help you walk through these decisions. But I think that you should know where to get good information, and you should have a good clinical sense of who's high risk, because those are the people that we really want to pay attention to. Knowing that COVID will become endemic, we now have to really filter people out to say, if someone's at higher risk, they really deserve the resources and the attention. And if people are lower risk, we're going to kind of leave them to heal on their own. And fortunately, the vast majority of low-risk people are going to do just that. So that's the kind of strategy that I think we're going to end up with COVID therapeutics. These are not going to go away. I mean, they might change. We might, switch out the arsenal here and there. But really, if COVID is around forever, then these therapeutics are going to be around forever also. And these are going to be the best layer that we have to keep people out of the hospital. As bittersweet as it is to say, America is a very reactive society. I think Americans as a whole would rather just take a pill after they get an infection than try to prevent the infection for some segments of the population. And so that's basically what the American public is going to come to expect from us, is to say, okay, I have a sore throat, whether or not I got the vaccine, now I deserve a pill, and we're basically going to have to prescribe them a pill. That's what we do with sore throats, with Z-Paks, and that's really what the American public has come to expect with so many other disease processes and conditions, is that they don't get the preventative piece right, but we do get the treatment piece, hopefully early treatment piece right, to keep people out of the complications phase. And I think that that's where people are going to expect these COVID therapeutics to land. And so therefore, I think, as much of a shift as this represents in our thinking about COVID, we really need to embrace this paradigm because it's here to stay, in my opinion. All right, so in terms of what is new in treatment, the NIH keeps reiterating, different recommendations. And so we've basically just lifted this from their panel's recommendation, which is pretty up to date, except it's not completely up to date. And what they're recommending, and so this is kind of the summary slide, is, if you have a patient that needs treatment, and we'll talk about who needs treatment, if they're ambulatory and don't need to be in the hospital, then you should offer them Paxlovid. If that's not appropriate or available, offer them Sotrova, and then remdesivir, and then molnupiravir last. And then what I had to do is add in a new monoclonal antibody, which was introduced just 2 days ago, and it has not yet made its way into the NIH guidelines. But I can guarantee you, probably by next week, this website will be different, and it will have this new monoclonal antibody somewhere in this list. What I've done is put it in the list wherever I think it most rationally belongs. But you have to understand that I'm not the NIH, and they're going to come in and just do based on their information, put it in somewhere on this list. But just keep that in mind, that there is this fifth drug that we're going to talk about today that's not in this list yet. Okay. And also remember, don't give outpatient steroids. We still see a lot of that happening. That really makes people get worse. It doesn't actually help for COVID. And so please don't give outpatient steroids thinking that that's going to help your COVID patient. We see a lot of people getting complications because that actually ends up hurting them in the course of their illness. In terms of severity, I just put this in here for your own review. Hopefully, again, all of you have a sense of what mild, moderate, severe, and critical illness means. But remember that for the purposes of mild and moderate illness, it's basically people have to have an O2 sat greater than 94%. And then mild illness is they have pretty stable vital signs, but they have signs and symptoms of COVID, meaning fever, cough, sore throat, headache, lots of flu-like illness symptoms here, but they don't have shortness of breath or abnormal chest imaging. So the green box here and the yellow box, that's really who we're going to focus on whenever we talk about outpatient therapies for people that are higher risk. Every once in a while, you'll get a high-risk person who's completely asymptomatic. I haven't really seen that myself a lot, but I imagine it could happen, and they may actually benefit from some COVID therapies as well. Okay, so in terms of who should get the outpatient COVID treatments, there's the long, very wordy list of tiers from the NIH on the right side, and then there's my very short, simplified list on the left side. So basically, if the person's immunocompromised, regardless of their age or their vaccination status, it's pretty much a slam dunk that they really need to get COVID treatment, or else they're going to land in the hospital. If they're not immunocompromised, meaning that they don't have an immunocompromising condition, whether that's malignancy or some other autoimmune condition, or if they're not on hardcore immunocompromising drugs like high-dose steroids or some other anti-inflammatory or immunocompromising medication like chemotherapy, then basically there's like, mild immunocompromising conditions, like you could put diabetes in there. There's a few other things that are mildly immunocompromising. That's not this group, okay? This is like the real bona fide immunocompromised group. Then you have elderly and unvaccinated or unboosted individuals. That's kind of the next tier down. And then the next tier after that is those who are elderly with risk factors. And I'll talk about risk factors in the next slide. But you know, you should have in your mind just a frame of reference. Like when I say, you know, a good sense of who's going to get sick out of your patient population that you see every day, you should understand that there's the immunocompromised. They're really going to get sick if they get COVID. The elderly who are unvaxxed and unboosted. So remember, if they got a vaccine, but they didn't get their booster, the vaccines really wane and they're not that good against the Omicron. So it's almost like they didn't get the vaccine at all. And then there's those with risk factors, and I'll talk about the risk factors in the next slide, who again, will not do well if they have a complicated pneumonia of any kind, but especially COVID. And so those are also considered higher risk individuals. Okay, so who is at high risk based on comorbid conditions? So again, familiarize yourself with these comorbid conditions so that, you know, again, you don't have to memorize them, but you should be familiar. You know, if someone's older, like for example, age is very much aligned with outcome with COVID, obesity, pregnancy, kidney disease, diabetes. Again, the immunocompromising state shows up here as higher risk, even though that's kind of redundant. Cardiovascular disease or even severe hypertension, which is a lot of people. Chronic lung, sickle cell, neurodevelopmental disorders. There's actually another line that I saw somewhere, which is like if the person has different medical machinery, like for example, if they're trach dependent or ventilator dependent, but still, you know, able to be in a home somewhere, then those people are considered higher risk. So just think about this as like a list of people that, you know, would be considered good candidates for protecting with the medications that I talk about. I'm going to rush through the medications, but I'm going to share out these slides for you to review the data. But basically, one of my pharmacy students at the Poison Center put together these really great slides for, you know, just reviewing all of the data based on these oral medications and the monoclonals. So we just decided to include them. The first one is Paxlovid. So, you know, if there has been a miracle drug, I would say the vaccines are a miracle drug with this pandemic. But outside of the vaccines, this one really does seem to be a miracle drug. It's a blockbuster and the data shows it. This is actually a combination drug of two different protease inhibitors. There's one called nirmatrelvir, which was the subject of a New England Journal paper this week. And then ritonavir, which is a good old HIV drug that we've known about for 20 years. So the combination of those is actually what's in Paxlovid. And again, the indications are going to be very similar for all of these, but this one is for both adults and pediatrics over age 12. And those who have high risk of progression. That's kind of how the EUA is named. It's dosed basically for a 5-day course, and it's a combination drug. So the pharmacy gives, you know, the whole course to the patient once you prescribe it. There is some dose adjustment that might need to be done, but basically it's not recommended if the person's in kidney failure or if they have cirrhosis. So beyond that, you really are, you know, if they have normal kidneys, normal liver, you can go ahead and give them the dose that's listed here. There's lots of potential drug-drug interactions, and that's the real drawback with Paxlovid. Otherwise, it would be just a magic bullet, but there's a lot of drug-drug interactions that make you think twice about giving Paxlovid to patients that are on a lot of other medications. This one is really, the reason people are excited about this is because basically people in the drug arm had a 0.8% related hospitalization rate, and people in the placebo arm had almost 10 times that number. So they basically showed an 88% relative risk reduction compared to placebo with very few side effects. Here's the drug interaction calculator that's being recommended. It's from the University of Liverpool, and you basically put in Paxlovid in this first column, and then with the co-medications, you can put in really any other medication that the patient is on, and then it will basically tell you, you know, whether this is a high alert drug-drug interaction, a medium or a moderate alert drug-drug interaction. It does require some clinical judgment. You know, there's some things like statins, which you can just stop and just say, you know what, for the next week, I want you to stop your statin. It's not going to kill you. And then that will get rid of that drug-drug interaction. For other medications like anti-hypertensives, you might want to recommend just the patient check their blood pressure and really just, keep a close watch on their vitals if they can, or have a way for them to call back or call you back if they get into trouble with dizziness or orthostatic hypotension, things like that, or if they have a hypertensive event. So there's different strategies that you can use, but really it's really a tool to give you a really good educational points for your patient so that you can make good decisions together about whether Paxlovid will work for them and what to do in the next 5 days while they're on Paxlovid. We haven't heard about any catastrophes with this. We've been doing this for just a handful of patients at the community medical centers. And when we call people back, they're tolerating it pretty well. We really haven't had anybody that's had to stop the medication for these drug-drug interactions. But, obviously everyone wants to be cautious in the early days of this. I really think we're going to see more articles coming out about, these are all theoretical drug-drug interactions. What's going on in the real world? No one really can answer that right now. But I think in the next few weeks to months, we are going to see real world cases of either, great outcomes or things that were really alarming in terms of the drug-drug interactions with Paxlovid, and that's yet to come. But for now, just proceed with caution and just know that these drug-drug interactions are the most painful part of Paxlovid. Otherwise, it's a great medication. Any questions about Paxlovid? And if you're wondering which pharmacies have it, I'm saving that till the end. There's a really easy way to find out the treatment locator that the HHS is using. And that gives you all of the area pharmacies that have Paxlovid. And right now we have about 4 or 5 pharmacies that are on that list. And we're getting allocations every week. It's not a lot, but we are getting them several hundred doses every week. Any questions about Paxlovid? All right, let's go to Sotrova. So this is an IV medication. This is a 1-day infusion. It's 500 milligrams. Again, same patient population. They're going to be ambulatory, walking, talking, normal O2 sat. Basically, whenever the Comet ICE trial was done, here was their inclusion and exclusion criteria. They were actually able to demonstrate a pretty good 85% relative risk reduction. So remember, for Paxlovid, it was 88%. Here it was 85%. But they basically had a pretty good outcome. This was in the pre-Omicron days, keep in mind. So you do have to interpret this in context, but it's still considered a pretty good antibody. And that's why the FDA has kept it on while they pulled other antibodies off the shelf. And there are many, many providers at this point providing this antibody all around the county. And Dr. Zweifler is very meticulously keeping a list of those providers. And we have that. We have a website on that as well that Sim can share. There's a new monoclonal antibody. So now for those of you providers that are doing Sotrova, you will actually have a choice. This new antibody is hard to pronounce, but it's called Bebtelovimab. And it basically is interesting because it was developed and designed against the spike protein of the Omicron. And basically the study that was done in Omicron patients. So that's why it's getting a lot of excitement. There's very limited clinical data. In fact, I couldn't even find a single article in PubMed to review this. But obviously, I kind of trust the FDA. I think that, they've reviewed the clinical data, and I'm sure it's out there. I just didn't have time to dig around too much for this. I think we're going to learn more about it. And I think, the big question is, does this replace Sotrova? Does this, where does this fall in that list that we shared earlier? And I don't know the answer to that right now. So I would say for now, keep Sotrova as the preferred therapy, but this is going to add to the national supply of monoclonals. So if you run out of Sotrova, this might be another option for patients that would otherwise get Sotrova. That's kind of how I would look at it. You can read more about it with the FDA news release. And there's also an FDA fact sheet for doctors that you should look through, especially if you're one of the monoclonal antibody providers. Remdesivir. So this one's an oldie but goodie. It's not a monoclonal antibody. It's just a straight up antiviral. But it now has found new life because it can now be used as a 3-day infusion for that same ambulatory patient population. So we've used remdesivir on the inpatient side for a long time. We're still doing that. However, they're now recommending that remdesivir for 3-day infusions can be used on the outpatient side. And this, again, provides about an 87% relative reduction. That seems to be about the best that we can do with these outpatient medications. Molnupiravir, so this is the last of the oral antivirals. So just like Paxlovid, this is going to be a 5-day oral pill that we give to people. This is just a single pill. And the big problem with this one is not drug-drug interactions, but it does have some teratogenic effects, meaning that it could affect the development of, growing fetuses or fertility issues. And so basically you have to recommend contraception for 4 days for females and for 3 months for males due to a concern for birth defects. And they don't want to give it to patients under age 18 because it might affect bone and cartilage growth. So remember, Paxlovid, age 12 and older. For this molnupiravir drug, it's 18 and older, and you have to tell people about the possible birth defects issue. Molnupiravir was shown to be kind of effective in the Move Out trial. Here's what the conclusion showed. Here, it only had a 30% relative risk reduction. So compared to 88, almost 90% with the other medications, this is only a 30% relative risk reduction. It's still pretty good, against placebo, it's still pretty good. It's just not great. And so that's why it's kind of the last of the medications that we recommend. The other good news about molnupiravir is that there is a crap ton of it. In fact, every pharmacy that we've allocated to just has a bunch of it sitting on the shelf. So it's being relatively underutilized, even with all of the caveats that I've just showed you. So basically, I would say find out more about it. There's probably patients that do want something, that do deserve something. And if Paxlovid is not available, then you can basically counsel them, especially if they're beyond their child rearing years. This seems to be like a great medication if they're, if it's a soft judgment in terms of their risk for complications and they're beyond their child rearing years. Molnupiravir seems like a really good option, and there's a ton of it available here in Fresno County and really all over the country. So here's this another medication that is not used for after people get COVID. It's for prevention. So basically, if someone's really high risk because of immunocompromising condition or immunocompromising drugs, they can actually get an antibody called Evusheld, which is a combination of these two different antibodies. And that actually lasts for like 6 months. And so you can protect that immunocompromised patient for 6 months if you inject them with an IM injection of Evusheld. And basically they can come back 6 months later and get it again. So basically it's every 6 months is what the FDA recommends of Evusheld for these patients. We also have a lot of this available in Fresno County. We're not using it enough. So whenever you have these immunocompromised patients, really refer them to these Evusheld clinics that can treat them and protect them for 6 months at a time. I think it's such a good deal. And unfortunately, we're not using it enough, probably because patients and providers aren't aware that it's available. So again, it's pre-exposure prophylaxis. You don't want to give it to them if they've already got COVID. But if, before they have COVID, if they're just worried, obviously they should get their vaccines, but we know vaccines don't work that well in our immunocompromised patients. And so that's why they came up with Evusheld. And this is really a great medication to consider. There's also a few people that have, allergies to vaccines or for whatever reason don't want to get the vaccine. You might want to talk to them about getting this. I feel like if people have Looney Tunes reasons not to get the vaccine, then they basically will probably not be too hot about getting this injection, but I might be wrong. Just talk to the patients and just tell them, look, I'm in your corner. I want what's best for you, even if you refuse the vaccine for whatever reason, or if you just can't get the vaccine because of allergies, then you might want to consider Evusheld because I think it'll protect you. So just feel free to have that conversation. Again, moderate to severe immunocompromising conditions are listed here. It's a lot of malignancies, as you can tell. So if you are in the oncology space, if you're working with oncology patients, please, please, please tell them about this. We're seeing a lot of oncology patients not getting this. And it's frankly quite worrisome because those are the people that are really high risk. Other high risk folks are people on high dose steroids or people on immunomodulating agents because of autoimmune diseases. And here's the trial that showed Evusheld. And again, it has a 77% relative reduction in the incidence of infection. So the key points, again, it's getting easier and easier to treat higher risk patients. This won't replace vaccinations, but it's just one more tool in our toolbox. The order of preference, and again, this has a little bit of subjectivity to it because I actually added the bebtelovimab, but the order of preference otherwise is straight from the NIH, which is Paxlovid, Sotrova, remdesivir, and then the new mAb, the bebtelovimab, and then molnupiravir. And remember, high-risk patients can get Evusheld. So the UCSF Fresno COVID Equity Project is doing Evusheld. This is actually from their website, and I've got the link right here for you in the bottom right corner. And then St. Agnes is also offering Evusheld, and I've got their form that people can go to and fill out online. There's other providers doing it. I wasn't able to list all of the providers that have access to Evusheld, but I really feel like, there's not enough demand right now, and we all as a community really need to talk this up because it's a great way to protect people for 6 months at a time, and this will really help us keep all these folks healthy and safe. So please spread the word about Evusheld. There's lots of doors for people to walk into and get it. And now that our numbers are coming down and things are hopefully settling down, this is actually the best time for us to really protect that patient population. Here's the Therapeutics Locator. So here's the website for it. And here's what it looks like. And it basically tells you, right there, how much Evusheld, molnupiravir, and Paxlovid is available in whatever area. And you can zoom in and zoom out. If you zoom into Fresno, you can see, it'll give you all these numbers for the Fresno area. And then all of these dots actually represent pharmacies with their phone number, with their address. So it's actually a very good locator to know about. I would bookmark it. Again, the bottom right of this slide has the same website location. And this is something that you should get used to looking at whenever you're doing your prescriptions, because this is your best bet for finding pharmacies that have this on the shelf. You should still call them because this is only updated every day. And so, there's going to be some changes during that day that are not reflected on this website, but this is a great start. And if you call the pharmacy that your patient is planning to go to, you can confirm that they have the medication on the shelf. All right, that's it. We have Dr. Takahashi as the person on the Google today. He actually invented the chickenpox vaccine at my alma mater, Baylor College of Medicine. So you could read all about him on today's Google. And that's all. We'll take some questions. Thank you so much. We'll send out these slides for you to look at. I know there was a lot of factoids and trivia on all those medication slides that we'll send them out so you can review it. Any other questions or comments? Hi, Dr.
Hi, Dr. Vohra. Yeah, you did a great job as always. And at a meeting a few weeks ago, we talked about Evusheld, and the question came up about cardiac complications. And the studies did show that there was an increased rate of cardiac complications, but it was really restricted to those who had existing significant cardiac disease. So if your patients do have existing cardiac disease, it increased the rate of complications from about 0.5% to 1%. So there was an increase, but again, really limited to those who have existing prior MIs, atherosclerotic heart disease. So for your patients who are, and also when they did the study in younger individuals, they didn't see this effect at all. So you have younger immunocompromised patients, or any immunocompromised patients who do not have underlying cardiac risk factors, you can very comfortably and with assurance reassure them that that the likelihood of a cardiac complication is extremely low for this medication. And basically, these folks who are our highest risk individuals are are basically walking around as if they're not vaccinated because they just do not produce the antibodies to fight COVID. So, you know, these are what the Evusheld is really a godsend for this population. So this is one that where hopefully, as Dr. Vohra had said, we can see some more patients coming in.
Thank you. I really appreciate those insights, Dr. Z. I agree. I feel like there's so many good things happening right now in terms of the therapeutics that it's a really hopeful time. And even those that are really, really vulnerable due to immunocompromising conditions can rely on several of the things that we talked about today to keep them safe and hopefully out of the hospital. We just need to do, I think all of us could be doing a better job just communicating that these things are available and really filtering out and finding the high risk patients and really getting them plugged in at the time that they need it. So I think that'll be the challenge for the weeks and months ahead, even outside of the surge. So Naomi's saying, we have a patient expressing dislike for us, still requiring masks. Oh, okay. That's interesting because I know that masking is a point of contention in the schools. I'm surprised that people are actually raising that issue in the clinical setting because really, it just seems like that's where the most vulnerable patients would be. And why would you want an outbreak in the clinical setting? I don't know exactly how to respond other than to say, well, this is just the law. I mean, CDPH has made it very clear that clinical settings require masks. And you can just post that and just say per CDPH mandate, we're requiring masks. It's not our rule. It's just basically what we need to do. In terms of screening, that has really, in my opinion, gotten very flexible and in many ways fallen by the wayside. A lot of clinical facilities are just are kind of using the honor roll system where people are just supposed to disclose if they have symptoms. You can certainly do more if you want by asking a questionnaire or even taking temperatures, although that's not required. So it's really up to you, Naomi, how much you want to enforce that piece of it. And that may actually be what's vexing people even more than the actual masking. I don't know. I don't want to presume, but it's certainly okay for you to just post the expectations for having no signs and symptoms of COVID, and then also the expectations of wearing a mask, and then making masks available. I think that also makes people very uncomfortable when they don't have a mask on them, and then they basically raise a big fuss because they're embarrassed that they forgot their mask. And so just taking away that piece of it by providing masks might actually get you a little bit more compliance. So hang in there. I know it's hard. Dr. Zweifler?
Yeah, I was just going to comment on that as well. And so we're seeing intense pressure around masks and vaccines, other kind of mandates. And we're seeing those rolling back. I'm here in the state of Michigan, thanks to the virtues of remote interaction, and the governor just recently said that schools don't have to require masks as they do in California. So intense pressure. That doesn't mean that masks do not work. And as medical professionals, I think we need to really separate where we want to be from the science. For those who say masks don't work, I would just ask them the next time they have their surgery or their dad has surgery, do they want their surgeon to do the surgery without a mask on, or the OR tech? So masks clearly work. The studies have been really powerful on that. The KN95s are extremely effective. We should be encouraging those more effective types of masks, reminding people that it's a respiratory virus that's spread when we talk or cough or sneeze, and reminding them of what are the highest risk settings, so crowded indoors around others who are unmasked and unvaccinated. So we don't need to apologize for requiring masks. And similarly with vaccines, that people, vaccines don't work. Well, they do work. We did see a lot of breakthrough cases with Omicron, but we still saw dramatically reduced numbers of hospitalizations and deaths in people who were vaccinated, and then even more dramatic reductions in those who are boosted. So even as we start to dial some of this back as a recognition that the majority of those who need it have gotten vaccinated, we're evolving in our understanding and our approaches, which is totally reasonable, that there's other factors besides just public health and medical considerations, but that doesn't take away the value of masks, the value of vaccines, the value of recommending social distancing in settings. So you don't have to apologize for that. And I think we really need to stand up as medical professionals to say, yes, we're following the science, we're doing what's right to protect health and safety. At the same time, we do adjust and adopt our how we approach this because we do consider as a society what are kind of the risks and benefits, and so that we can acknowledge that. But as medical professionals, we can stand firm on the value of some of these interventions as we consider how do we protect health and safety.
Well said. Thank you, Dr. Zweifler. Someone's asking about how many healthcare workers have gotten their boosters. That's a good question. We'll try to track down. That's an epidemiology question that I don't know that our epi team really have access to locally, but we can ask the state to see if they're keeping track of it. Because I'd like to know myself how that's going. I know that the booster deadline was pushed back to March 1st. So we may have to wait till after March 1st to really get good information about how many people actually complied and what's going to go on with those who didn't. Obviously, there's exemptions that are allowed, both medical and religious. So we understand that it's not going to be 100%, but it should be, hopefully close to 100% for those who didn't get the exemptions because they've had an extra month to get their boosters. Any other questions or comments? All right. Well, I really thank you for your time and your flexibility with changing our time to meet today. I'm actually going to be taking a week off next week, so I don't think we'll do an update next week, but we'll come back in March and have lots more information for you. If there are topics that you'd like to cover, especially if they're non-COVID topics, then please let us know, because we really want this to be a very useful program for you. And we know that you're doing wonderful things and we'd love to showcase them. And hopefully we can all learn together and continue this great partnership that we formed just to keep our residents here in Fresno County safe. Thank you all so much.
Great. Thank you.
Thank you.
Thank you, Dr. Vohra.
Thank you.